So welcome to the fourth lecture of the 21st Annual Lefeber Winter Series on Aging. This lecture series is in honor of the memory of Dr. Edward Lefeber. He was a Galveston physician with a passion for geriatrics, and he contributed to the development and growth of geriatric medicine here on the island. Today I have the distinct pleasure of introducing Dr. Pamela Duncan, a nationally and internationally renowned expert in health policy, outcomes research, and clinical epidemiology on the post-acute management and prevention of stroke and falls in older adults. Dr. Duncan is professor of neurology and a senior policy advisor for translational outcomes at Wake Forest Baptist Health. She holds secondary appointments in the Division of Geriatrics and Gerontology and Public Health Sciences and in the Translational Sciences Institute at Wake Forest University. She obtained her bachelor's degree at Columbia University and then went on to get a master's degree and a PhD in epidemiology, both from the University of North Carolina at Chapel Hill. Actually, her bachelor's was as a physical therapy, so she's a physical therapist. Dr. Duncan has led or co-led a number of studies funded by the NIH and other agencies related to falls in the elderly and in stroke survivors. She has published more than 170 papers in peer-reviewed high-impact journals and has developed a number of measures of balance and stroke outcomes, analyzed physical determinants for falls in the elderly, evaluated benefits of strength training to reduce falls, and developed international trials to evaluate home-based exercise for those who suffer of an injurious fall. She's currently a member of the North Carolina Falls Prevention Coalition, which brings together researchers, planners, healthcare providers, housing specialists, aging services providers, and many others to work together to reduce the number of falls and fall-related injuries in seniors. She is an investigator of a CDC grant on fall prevention and of the STRIDE study, which is also, of which we are one of the clinical sites here, and so we collaborate with Dr. Duncan. Dr. Duncan also focuses on the development and implementations of strategies to improve the care of in functional status for individuals at the highest risk of hospital readmissions, which is very dear to us, especially for Medicare, Medicaid, dual-eligible patients. She has developed coalitions of healthcare providers, payers, and community-based organizations to integrate medical care and community services to improve health management in medically and socially complex patients. She's been a Wake Forest champion and leader of multidisciplinary teams to align and integrate acute care and post-hospital care services in home health, nursing homes, dialysis center, primary care, and palliative and hospice care. For her work, Dr. Duncan has received many accolades and recognition. In 2012, she was selected by the Centers for Medicare and Medicare Services, the CMS, into its Innovation Advisors Program, which tests new models of care for those who are covered by Medicare, Medicaid, and the Children's Health Insurance Program, the CHIP. In 2013, she was selected for the roster of Fulbright specialists to be eligible to collaborate with global partners to develop and lead interdisciplinary seminars and develop curricula to prepare the next generation of clinical and public health providers. She has led international trials on fall prevention in Singapore and served as a visiting expert for the Singapore Ministry of Health for the development of integrated care models. She also served for several years on the external advisory board of the Canadian Stroke Network, a funded program to implement best stroke care practices for prevention, acute management, and rehabilitation. Today, she will talk about her brand new clinical trial funded in 2015, I believe by PCORI, It's a really big trial, it's a $40 million trial, which is to implement and evaluate an evidence-based comprehensive post-acute stroke services, the COMPASS model. So please join me to welcome Dr. Pam Duncan.
All I can say after an introduction like this, wow, well, I'm just an old lady. So I've been doing this for a long time, a 40-year career, and I am really pleased to be here because I know so many of you, and certainly have known Betty Protis for many years, and we grew up professionally together, and Ken Odenbacher, and I can only say that all of us have shared this incredible passion for this arena of how to bring the best of rehab sciences to frontline clinical care. And there's no group of esteemed colleagues that have worked more diligently than your own faculty here, people like Betty and Ken and all of you. And it's so heartwarming for me today to also recognize all this young talent you have and the expansion of rehab sciences. And I've had the opportunity to work here with the Pepper Center over the history of this Pepper Center and the great work that is being done here through the Pepper. But we are at a crisis in healthcare, and if you've been on the front lines, you know it. We have absolutely developed through the auspices of the research in the aging centers and the Pepper Centers and Betty's work and Ken's work. We have all very thick CVs. But the challenge to us is, how do we really change healthcare and bring the best models of healthcare to the front lines? And this is what this trial is about, and that's what the Patient-Centered Outcomes Research Institute is about. It's not just developing a large portfolio of funded research or very thick CVs, but really, do we impact what's meaningful to patients and their families, and do we really begin to test in real world situations how we do this? And so that's what the COMPASS trial is about. I've violated every presentation rule I've ever made. I've got too many slides here, but don't even take notes. We're going to send you PDF copies, and most of them are just background slides. So if I can just start out by saying, what are the key messages? And if you remember these things as we deal with stroke, is the key COMPASS messages, what we're trying to do is to know the patient, and know the patient not only from the medical perspective, but from the social and functional determinants of health. The other important message in this study is that stroke patients, the average age of stroke in this country is not 85, it's actually 67, and the majority of stroke patients go home immediately after a stroke, and they're not left without overwhelming disability, but some minor and moderate disability that contributes to their ability to manage health. So the first message is patients recover and they can improve their independence and health. And the third message is, let's find the way forward. Let's not overwhelm patients or providers, but focus on key aspects of their health that they absolutely have to manage for optimal recovery and independence. And the fourth point is, don't forget the caregiver. That the care of patients today, especially in modern healthcare, is we're shifting patient home. We have to think about the caregiver and their ability to manage the situation. The other major point is it's not an episode of care. As you'll hear me say over and over, we have revolutionized acute stroke care in this country. I was in Kansas City in the 90s where a group of people got together and said we're going to certify stroke centers, we're going to have practice guidelines, and one day we'll have quality metrics. And everybody said, well, that's impossible. And now this is the standard of care. And we've shifted mortality in stroke in this country from the third leading cause of death to the fifth leading cause of death in this country now. However, we haven't really changed the residual functional problems and the morbidity. But it's not just an acute episode of care. The acute care stay is about 4 days in this country, and patients go home with unrecognized functional and cognitive limitations that influence their ability to manage health. We have to begin to think about patients not just as an episode, but across a continuum with multiple providers. And the most important point is we cannot solve all the patient's problems, and we really have to think about self-management and coaching the patient and their families to better manage their overall health. So in all these slides, that is the real purpose of this COMPASS study, is to really re-engineer healthcare to manage that patient once they leave the hospital, go directly home, so that they'll have better health, recovery, and independence. I certainly didn't do this without many, many valuable colleagues, Dr. Cheryl Bushnell, who is the co-PI head of the Comprehensive Stroke Center, Wayne Roseman at the UNC School of Public Health, UNC Gillen School, who's an epidemiologist and has worked in stroke across the state of North Carolina for years. We also, there's what's unique, and I'm not going to delve into a lot, but the PCORI, which is different from NIH in many ways, is you can't design, you can't design a study or do anything unless you engage the patients, the caregivers, and all the providers, and all along the way in developing the question to establishing the outcomes. We have groups of patients working with us side by side, and Dr. Sabina Gazelle leads that. And of course, no study exists without the incredible role of world-class biostatisticians. And here you go, here's the rest of the team. There's every discipline represented on this team, from nurse practitioners to geriatricians to pharmacists to physical and occupational therapists to speech and language pathologists. This is funded by PCORI, which many of you know is a new institute. They really don't call themselves federally funded. They're a lot unlike NIH. They was really developed under the Obamacare plan to say, look, PEPR centers, NIDRR, we've been doing research for years, but wait a minute, how long does it take us to get to that research to the front lines of healthcare and meaningful to patients? And they are commissioned to bring this to real world practice, and we don't have a 17 or 18 year funding. So this is funded by the U.S. Treasury Department, and it comes from a small fee on Medicare and private health insurance, and it's really only in existence right now until 2019, and it has to come up for renewal, so they have to deliver the results. So what is a pragmatic trial? The pragmatic trial is that you are really going to deliver an intervention to all patients in the context of real-world practice with real-world practitioners. So we don't go out and selectively recruit patients, but if you're in a health system, all patients are eligible for the intervention. This trial series was first developed by PCORI, and the first funding round in spring of 2014, they had a call, and we actually were notified in 2015 that we were funded, and we were one of 5 studies across the country funded. In order to be approved for funding, there was a 2.5% probability of getting the study, and there's some days now I know that one of the other 98% didn't succeed, and sometimes maybe I wished I were in their court, but it's a lot of work to implement this. But it really was not only focused on the scientific merit, but the last 2 points are so important. It had to be patient-centered, driven by the patient's perspectives, and you had to have patient and stakeholder engagement. This will be in your slides, but this is a comparison of what we usually call typical research to pragmatic trials. The important points here I'm just going to highlight. Number 1, we're not looking at absolute fidelity of the intervention. What we're saying in this trial, if you're discharged home from a hospital participating, you're in the denominator, whether you got the intervention or not. You're there to scale it to everybody who goes home. The follow-ups have to be simple and can be easily captured, and we're not looking at compliance and adherence, for example. So why would the federal government invest, or PCORI, but the federal government too, invest in this comprehensive post-acute stroke services? First of all, what happens to the stroke patient after they go home is a big black hole. There's huge variability. There's nobody in this room who knows and has researched this more than Ken Ottenbacher. It is a holy mess. Deciding whether a patient goes to SNF, the inpatient rehab, home health, and let me tell you, Medicare, Medicaid, all payers are trying to curtail those services as fast as they can because 73% of unexplained variation in Medicare cost is in the post-acute arena. So what happens to the stroke patient after they go home or after they've been discharged from the hospital is quite uncertain. But what we do know is that there's many gaps, and 42% of stroke patients are referred are not referred to any post-acute services. And if you were younger, it was probably more likely you didn't get any services, 65%. And there are no quality performance indicators for those patients who go directly home. But what we do know that happens to these stroke patients is they have the highest rate of readmissions of any group, even compared to those who've had a stroke, go to skilled nursing or inpatient rehab. 24% readmission rate within 90 days. 75% of them fall, and if they fall, they're 4 times as likely to break their hip. And this is the most depressing. 85% of all stroke patients have high blood pressure, and it's the #1 preventable cause of stroke. But 30% of stroke patients, when they go home, actually control their blood pressure. So we're not manage them medically and stabilize. And it's not, there's this complex issue about why not. And when we compare acute deficit care to post-acute deficit care is very poor. In other words, patients are not treated consistently for management of depression, high blood pressure, and mobility. And they have poor medication adherence. And some patients and families, though, do refuse certain levels of care, and we need to understand what that is. Now, I'm leaving here first thing tomorrow morning, and I've been in the acute stroke world for many, many years. And I've been preaching for at least 40 years that we have to think about that population beyond the acute neurological event, which is brain damage, in a patient who has chronic comorbidities, right? And just recently, just in the last few months, Joe Broderick, who's probably one of the leading acute stroke neurologists in the world, wrote this position paper, is that the new frontier is to really manage these patients as they go home in transitions. But in doing this study, one of the requirements is you have to listen to the patients. So we went across the state of North Carolina, interviewed patients, and let me tell you, patients who go home are not happy campers. They feel like that they have been dropped out of the airplane when they get home. One of our most influential leaders in the state of North Carolina, the member of the American Heart Association staff there, advocacy, husband had a stroke. And she said, I have everybody in the state on speed dial. I could have called anybody, and I was so overwhelmed when I got home, understanding these new complex medications, how he was now cognitively and physically impaired. I just didn't know what to do. But this is common. This is a 60-year-old, very well-educated man who was on the board of directors of a hospital in the eastern part of the state, had a major underlying cardiovascular disease, and had a stroke. And told, oh, you've had a very mild stroke, go home, you're just fine. When we got home, he said, ooh, I couldn't manage my medicines. And he realized he had some bath deficits that were unrecognized, and guess what medicine he went on? Warfarin, which is one of the high-risk medications that you have to regulate your dose, and he didn't have the ability to do that. So these are very common problems we see every day. So our challenge is, how do we manage this in a very complex health system that we have? And can an intervention to improve care for stroke patients, regardless of the setting, truly be implemented in real-world practice in the U.S.? And what might be the best method for doing this, and what is our message? Now, you're going to hear us talk about the COMPASS program, and COMPASS stands for Finding Your Way Forward. And we've developed our messaging, and our messaging is just not to patients and caregivers, it's to every provider, primary care provider, every rehab, that there are 4 things, 4 directions of this compass that you need to manage to move forward. Now, let's back up to the evidence. We have some pretty overwhelming evidence from the European literature that early supported discharge after stroke really manages them very well, decreases morbidity and mortality, but that model of care, they have been in the hospital for days and then they get early supported discharge, which isn't consistent with what we see in the U.S. And then we have Mary Naylor's transitional model, not just for stroke, but for chronic management, said that if you had a nurse practitioner clinic, you could really improve outcomes. However, Mary Naylor's model never improved the functional outcome of the patient. It reduced readmissions. She didn't have an integrated program of understanding management of the patient's physical function. And here's a recent review out of the Journal of Neuroscience Nursing of the transitional care models, and it's not very positive that the current care coordination models are not working. So we have a lot of evidence that I don't need to review here for this group, but there's no scientific doubt that with the right structured and progressive programs, both occupational and physical therapy after stroke can significantly improve gait speed, quality of life, and motor recovery. But those levels of therapies are not what are consistently provided in real-world practice. So what is the real purpose of the Compass? It's really to address the needs of the patients and the caregivers for optimal outcomes. Our goal is to connect the hospitals, the community providers, and the community agencies for improved management of their patient within their community. And most importantly, every patient will get an individualized care plan based on their functional and social determinants of health, as well as their underlying major risk factors for stroke. It will all be individualized. So, where did we get this idea? Dr. Cheryl Bushnell, who is a stroke neurologist, has been working through internal funding for several years now with a program called Transition Coaching for Stroke. And let me tell you, this has evolved over time to the model that we're talking about today. It started with telephone calls and trying to get the patients back in, but then she began to structure it, as you'll hear about the Compass model, with nurse practitioner visits. So the nurse practitioner really has a very systematic way of evaluating this patient when they come in, and she works with a nurse to make sure that those services are in place. The most common thing that we see is the hospitals don't do a bad job, you guys. They really don't. The patients don't remember a thing they said, right? They're overwhelmed, caregivers are overwhelmed. They may have ordered home health, and now in today's market, I am not exaggerating, everybody wants to reduce 30-day readmissions. In our healthcare system, when I ran the transitional program, I found out that the patient could be home and 5 different groups could have called that patient to try to manage their readmission. The provider, the nursing staff by the bedside, the transitional care unit, the insurance agency, right? So, and by the time home health got there, they said, well, who are you and why are you here? I don't want to see you. So a lot of the patients would just close the door on needed services because they didn't know who was coming at them. And so this is to bring order. Now here's data that's going to be presented actually tomorrow at 7 o'clock at the ISC meeting. And again, you'll have all the slides, but what were the factors that are associated with our cohort of patients we were treating at Wake? Well, first of all, the biggest factor if you were going to be readmitted were, have you been hospitalized before? Another big factor if you had a prior stroke, and no duh, for those of us in geriatrics, the more comorbidities you have, the more likely you are to be readmitted. So when we go to manage these patients, and again, I've been in the front lines of physical therapy, we think about neurological recovery. It's not just managing their motor recovery, but managing their health and their ability to manage. And the good news is that with this study, we found, which was a quality improvement study, right? It was not a research study. We got IRB waiver to do this. We found that we could reduce the readmissions of our stroke patients who got back to us by 50%, controlling for their multiple comorbidities and their prior stroke. Now, the skill sets of these nurse practitioners they weren't stroke specialists. They were actually nurses trained in primary care that we taught stroke management models. But we're managing the patients as a chronic comorbid condition that needs to improve recovery and function. So what we're doing is now in pragmatic trials, they say, oh, I'm not going to come in here and pay for this intervention. You've got to use the existing healthcare system to do that. And so what we're doing is using the transitional care codes that Medicare put out in 2014, and we want the health systems to also endorse the chronic care management codes. And we're doing this as part of this early supported discharge, but here's the big problem we're having. The patients who are readmitted are not 30-day episodes of care. All that we're doing when we try to manage these patients for care coordination for 30 days is create another silo. These are patients that need care and management throughout the continuum. So we've just, actually all these 30-day readmission programs aren't working either, right? Because you're not managing the patient for their care in the long term. It's just to keep them out of the hospital for 30 days. So who are our patients in the study? Anybody who's discharged from one of our participating hospitals who's being discharged directly home. And we're excluding patients in skilled nursing and inpatient rehab. We only include those patients who speak English or Spanish, and we're not including patients under 18. Otherwise, you're in this study. We're not randomizing patients, we're randomizing hospitals, and we're stratifying hospitals by the volume of patients they see and whether they are a primary stroke center or not. And our primary outcome, PCORI said, had to be patient-centered. It had to be a measure developed from the patient and caregiver perspective, and there was only one measure that had done that, and was the Stroke Impact Scale, which I started developing in 1994. And so we demonstrated and have numerous articles that this was developed from that perspective. But if you ask patients, what are they most afraid of? Not dying. What are they most afraid of? They're afraid that they're going to lose their independence and function. And this is what this is about. Dying, okay, I might be able to accept that, but I don't want to be dependent. And that's been shown over and over and over again. So we have secondary outcomes. The other primary outcome, which is a secondary, is what happened to the caregiver strain at 90 days. And then we've got all your typical readmissions at 30 and 90 days, mortality, healthcare utilization, and all these secondary measures of cognition, depression, fatigue, and blood pressure control. Now, we're integrating all these data systems. We're going to capture the patients acutely, characterize their stroke with a stroke care card. Then our next assessment for outcomes is 90-day prospective interview of the patient or the caregiver, and then we're going to integrate all the claims data. So we'll have clinical data, patient-reported, caregiver-reported data, as well as administrative data. The primary outcome, I've never done a study this way and this fast in my life, is we will be in the field. We've actually delayed it till now June or July, but in 2017, the end of the year, we'll have the first results. That is amazing, right? Now, in addition to all of the things that we're going to do, we're going to have massive training programs in the intervention communities, not only with the primary care docs, with the nurse practitioners who are doing the intervention, but we're bringing home health providers in, and we're not letting home health do just what they want to. Doctor says, this is the care plan. When you go in there, review the care plan, this is what we expect to be as part of your care plan when you get home. And we're working with them in the community, both outpatient and home health therapies. And then we're developing quality performance indicators for the care, how quickly you saw the patient, and how many of them were seen in 7 to 14 days. So there are two phases of this study. Phase 1 is early randomized hospitals to the intervention or to usual care. The other hospital says we won't participate unless you'll eventually offer us the intervention. And so in phase 2, the first phase hospitals have to sustain the intervention, and the second phase hospitals have to implement the intervention. But the primary outcome is at the end of phase 1, okay? So in the end of 2017. So here's your randomization. You're in the hospital, you're a stroke patient, you're going directly home, you're in the study. The hospital gets the COMPASS intervention or usual care, and then the COMPASS intervention is over at the end of the year. They are expected to sustain it. We will measure if they do. And the usual care group will get the intervention. And we will also look not only at the primary outcome, but we will look at sustainability. So there will be 6,000 patients in phase 1, 3,000 patients in phase 2, and 50 hospitals from the mountain to the sea, both in rural North Carolina and the big regional populated areas like Charlotte and Raleigh-Durham. The care model is this. So what we heard from patients and caregivers is, oh my God, everybody just spews information at me. I don't even know where to begin. I don't remember what they said. What's important? What do I need to do? And so we listened, and we also integrated our medical and rehab knowledge about this. Is look, let's message very simply to the patient. All of you know what FAST is, right? All on your billboard here, you know what FAST is. Marketed everywhere. What are the signs and symptoms of stroke? Get to the hospital. So we're saying, find your way forward after stroke, and you need to know the directions of the compass. First one, know your numbers. The most important thing, know your numbers, manage your blood pressure. Yes, we will educate you about INR if you're on warfarin. We'll deal with that, hemoglobin A1C and cholesterol. But You've got to know your blood pressure, and you got to manage your blood pressure. The other one is engage, and it is get up, be active, get moving, right? And if you're active and moving, be safe, and engage in physical activity and your recovery program. Support, ask for support if you need it, especially for caregivers. And last but not willingness is manage your medication. So this is our emblem. Everybody, providers, home health providers, therapists, OTs, speech and language, nursing, primary care, you got a message on the patient, compass, find your way forward, okay? And then we've developed materials for the patients and also for the caregivers as well as the providers across 4 dimensions. Movement matters, medication matters, depression matters, and movement matters, depression matters, medication matters, and there are 4. Okay, I'll come up in a minute, in a second. Cognition and communication. So we've got all these materials developed so that it's very simple. Get up, get moving, manage your medications, and depression. So those are the 4 dimensions of health. Now, what's our processes? Our processes are, there will be a 2-day phone call immediately from our team, not the health insurance, not your transitional care unit, but the team that took care of you in the hospital. And we're going to ask you if you've made your appointment, have you started your therapy services, have you reconciled your medication, do you know the signs and symptoms of stroke? A real simple call. And oh, by the way, you've got an appointment to see us or your primary care physician practice. We may be in some of those practices in 7 to 14 days. Do you know that you're supposed to be here? Do you need transportation? Come to the clinic. And then we will have this systematic communication. Now, what the nurse practitioner does is they, in that visit, have very systematic assessments of the patients and not wait for an OT to go over here and a PT to go over here and a nurse to go over here and a doctor to go over here. Ask the patient and evaluate the patient consistently for their functional assessments, their social determinants and the medical, and then that will feed an eCare plan that I'm going to share with you. We provide those care plans to the doctors, to the therapist, to the patient. We coach them on that, and we provide care plans. So this is just an example of all the components of it that you are going to see when you get the entire slides. But I want to spend a minute about what's unique. There's an application that's going to support this process. Again, no offense to all of us who've been doing this, and Ken, don't shoot me, and Betty, don't shoot me, but we have spent a 40-year career, maybe you guys aren't that old, looking at outcomes and collecting outcomes. And we've been thinking about the FEM for years, and we've been thinking about the OASIS and the MDS. Well, those, except for the FEM, the OASIS and the MDS were developed for regulatory purposes, not to inform patient care. And the FEM was developed for an outcome measure, right? So CMS is now saying, wait a minute, what we want to do is going to be as important as your medical evaluation is that you evaluate the patient during the visit for their functional and social determinants of health, and that should drive your health care plan. So this development of an electronic care plan is part of our product in the PCORI. Now, here are 3 Medicare requirements for TCM, chronic care management, and the annual wellness visit. Now, with the exception of gerontologists and maybe PTs and OTs, most primary care providers wouldn't have a clue how to evaluate all this quickly, right? And they might come in with a research battery of assessments. It's not feasible in real world practice. So what we're doing is saying it's not enough just to ask and assess those. Do it quick, do it simple, and use that information immediately to inform the care. So the key goals of the eCare plan is know the patient from the functional and social determinants of health as well as the medical. Discuss with the patient and family what those deficits are and set their priorities for what they want to manage, and most importantly, deploy the right care at the right time. So I'm going to pause here and tell you that in our clinic, these are the stories we see every single day. But this one resonates probably with you all more than anyone. 40-year-old who had multiple embolic strokes of unknown etiology. mild stroke, couple of days, we're going to send you home, we're going to bring you back for all these extensive workups to find out why you've had multiple embolic strokes. She comes to our 7 to 14-day clinic. We didn't see her within 4 or 5 days, which we can. Her mother and sister said, there's something wrong with her. She won't take her medicines, right? And she comes in high heels with a note that you're going to sign that I can return to work. And we do this systematic assessment of her, and whoa, a 40-year-old PhD couldn't do a TRAILS B, 1A, 2B, 3C. And she couldn't recall, and nobody detected it. So we back her up, which is one, if you pick that up, you better do a more extensive cognitive assessment, and she had major executive function problems, and she had major visual spatial problems that no one picked up. Totally compensated because she had good language and she was well educated. Now, if we had let her return to work, she would probably have lost her job in weeks, right? So here's a flow diagram. We do a 2-day assessment of the patient, standardized. Within the clinic, a post-stroke self-reported functional assessment with a couple of performance items. The nurse practice is a very standardized assessment, and if it's depicted that the patient, after the post-acute functional assessment, needs a caregiver, we've programmed algorithms to determine that, then we'll ask the caregiver about their health and are they willing and able to take care of this patient. That then, with algorithms, immediately informs an eCare plan across these four domains of the compass. Know your numbers, ask for support, engage, and willingness, and then we send that forward. So again, these are all things that are highly consistent with CMS requirements, that our post-acute functional assessment addresses each one of these domains. And that is totally consistent with the Chronic Care Management Code. And honestly, we've got it adaptively programmed with 10 questions. If you pass all that, okay, you don't need to go on to more substantial assessment. But if you fail that, then we go on. And this type of assessment in real world practice can be done in 15 minutes, right? If there's variability in it, but on average 15. And then we have questions for the caregiver, all delivered on a handoff pad. When we close out of that assessment, it generates an immediate report, a handoff report. Now this is what we call a worst case scenario. So we created the worst case scenario. It will tell you immediately that the patient had medication management problems, they were a faller, they had physical mobility problems, they had ADL, cognition, depression, they did not have a primary care provider, or they weren't going to see him, they were using the hospitals frequently, the caregiver health was poor, and the caregiver stress was high. Now we just programmed this as a worst case scenario. But if you only had one of those domains, that's the only thing that would follow. It generates that report immediately. The APP gets it before she sees them, she goes through evaluation, and then she adds 4 other domains. We thought it was more appropriate for the nurse practitioner to ask about alcohol and drug use, which we have a big epidemic of stroke in North Carolina, and young strokes because of cocaine. It's very, very bad. So that was, we didn't think should come from just a self-report question, but exploring. And then they report the values for blood pressure, LDL, and hemoglobin A1C. And if they fail the 3 items of cognitive screen, they will do a MOCA, and if they fail the PHQ-2, they will do the PHQ-9. So from that will all become and generate a provider report. But this is our screen, all done electronically on an iPad. You click which assessment you want and can quickly access it. Here is just an example of one of the questions. Falls, okay, why did I pick that? Alina, okay. So the first question is, have you fallen in the last 3 months? In the last 3 months, did you get injured? Did you have multiple falls? And have you fallen since stroke? Now, it is required now by CMS to ask those questions, right? If I'm 65 years old, what happens? Did you fall? Yes. Okay, now I know that. Bye, you're gone. When we did work with falls and in Duke, and we looked at that question, they always ask it, but guess what? They didn't always deploy an intervention for it. This says you've got to deploy an intervention. So then it will tell you, so what we do then is generate an eCare plan that looks like this. And again, we've just given you examples. It will immediately tell you, finding my way forward for recovery, independence, and health. And we will have asked the patient what their goals are for recovery. This mock patient said independence and health, and I want to return to work and be with my friends. But what we found, that their blood pressure was 170/80, not a good thing, right? And the message why it's important to control your blood pressure and what do you need to do. And we do that for physical activity, for falls. And so for each one of these domains, it tells the patient why it's important, why you need to be part of the management, and it also tells us how we need to make the appropriate referrals and connections. But regardless of who you are, and you come in and you look like you're perfectly recovered, well, if you've had a stroke, you've had some underlying health issues, right? So everybody gets this message regardless. My health and my recovery require that I manage my blood pressure, am physically active, ask for help when I need it, and take my medicines correctly. Everybody gets that message, regardless if you're perfect. Now, the other thing is, what we found is there are more resources than you think. So we've been very paternalistic in rehab, right? Okay, come see the therapist, come see the OT, I'm going to see you for this many visits, and okay, then bye, you're gone, right? Well, we're trying to engage patients with what are resources in their community in which they can remain, for example, physically active. So we have gone in, mapped all the resources in the community, and immediately, depending on what their needs are, it will list for them a resource that is available to them. Like, we have one of the most expansive falls prevention coalitions in the country. These patients high risk for falls. It will tell you in your community, you can go to the senior center, you can engage in this falls prevention. And then, last but not least, it ends with a summary report. So it flags the really major problems, that you've got a lot of challenges, but you got to pay attention to these. Now, one of the things that we see a lot, unfortunately, is that mother had a stroke. They always promised mama they'd never put her in a nursing home. They'd always take her home, right? And what we see is, oh, wow. They did it, but they can't manage the patient when they get home. So this is another chance in which we say to the patient and the family at this visit, you know, mother, really, we need to explain to you that rehab in a nursing home doesn't mean you can be there forever, but we need to get you back in a more comprehensive rehab program. You don't have a caregiver at home, you're very dependent, all the dimensions of what we require that. The other thing that we do, and actually I'll tell you, we all are on this bent, geriatrics, especially about palliative and advanced directives, but I tell you what, patients have a totally different opinion of that than we do. So our issue was, okay, we're going to ask patients, do you have an advanced directive? Our stakeholders did not want us to ask that question. What we do is we ask the patient, do you rate your health good, fair, poor, or excellent, whatever. And if your health is less than fair, then we ask you, do you have an advanced directive? Yes, no. And if they say yes, okay, bye, you're gone. No, would you like one? And then we begin the conversation and give them directions. What we've heard from patients and caregivers is they don't want to be told right after a stroke that I need to establish advanced directives. They only want to hear about hope and I can get better. So don't start talking with me about this right now. And they also said this conversation belongs with my faith community and my primary care doctor, right? So we only begin the conversation, consider it, here's some information, and we let home health, the primary care provider, know that this is where it should be done. So again, it's not that we are going to care coordinate, but we're going to care manage, and we're working with the patients to begin to understand this, and we're not only seeing them for this visit, but the nurse practitioners are a resource to the primary care providers, because if you think about it in primary care, what happens is that patient had a stroke. Sometimes the primary care doctor doesn't even know the patient had a stroke until they show up in their office, and they're not going to be able to manage all these things in a 10-minute visit. So we are a resource to them. But when we think about this, it is truly a multidisciplinary approach when we manage these patients. And we are here to integrate the medical, social, and community resources for the patient in their respective communities. So as we roll out these programs, very similar to the Falls program, we're going in the communities, we're training the APP and PAC team, but we're calling together the home health providers, the outpatient therapists, the primary care, the pharmacist, and the area agency on aging and other programs within your community. And in some rural communities, you know who we call together? Is EMS, because they have a paramedic program that goes out and checks on these patients. So what's in your community, know that we're in the community and we'll be making referrals to you. So here is, and again, you'll all have this, is home health. You're going to get this patient. Here's your checklist. This is what we expect. If it's a COMPASS patient, you see them, we want you to review the eCare plan. Blood pressure, right? Know your numbers. They're on INR values, that they know, the patient knows that. Evaluate them for medication management, engage them in movement matters or communication matters, and make sure that they are referred to other services. It's pretty prescriptive. And you know what? We just had our first big home health meeting, and do you think they were resistant? Because why? Because now they have gone to 5-star rating. And we developed this with all the major home health stakeholders in the country came to Winston. We sat down with them and they said, what are your problems as a chief executive operating clinical officers of home health? And they said, no offense, therapist, these therapists won't listen to us. They want to do what they want to do. And everybody comes in with a different bag. So you help us provide the structure, evidence base, we will deliver it, and we will train our staff to do it, right? And these are the important points of what we need to manage. So obviously I'm a physical therapist. Here's an example of movement matters. Movement matters. It's not just for your neurological recovery, but if you don't get up and moving, guess what? You're at higher risk for stroke, right? You're at high risk for DVTs, and if you're not safe, you're going to fall. This is one of the most vulnerable populations for falls. And then you really need to message to the entire community. Area Agency for Aging across the state of North Carolina, in fact, they just put out their major brochure to every agency and health system, and they featured the COMPASS study, that this is a model of how they want to partner with health systems to deliver their services at the point that's critical. Now, they have their own challenges right now, and they're willing to work with us because they see as we go to bundle payments, they may be able to get extra services. In our state, you need Meals on Wheels. You know what the queue is? 6 weeks. What is it here, right? Does anybody know? Well, if you've been in a hospital and disabled, you can't wait 6 weeks to get a meal, right? So you got to bring these services to the point of immediate need, not just social need. And we're working across the state. Here's an example of their brochure that they've just put out across the state that they're going to be partnering with us, and this is why it's important. Here are our key area agency on aging partners, and we have already connected with the Falls Prevention Coalition to get these patients involved. And this is, we don't need to reinvent the wheel for everything. Probably the most influential group in the state of North Carolina is in the eastern part of the state. They if you haven't, and you'll have this website, it's absolutely the most effective information I've seen on how to begin the conversation about advanced directives. And they tell you it's a multi-tiered conversation, and just begin the conversation with them and let them take their time to deal with it. So in summary, COMPASS addresses the needs of the stroke survivor and caregivers by addressing the gaps in post-acute care practices, providing holistic post-acute care, and providing the structure and process processes to do that, and keeping all providers on the same page with the patient. If home health can't go off and do their thing, primary care, these are the key messages we all need to message consistently. So from this perspective, what we're trying to do is intervene at the system level of care. And most of you also know that probably stroke is going to be the next bundle payment right? And I can tell you, acute hospitals are clueless how to do this. And Medicare doesn't care. They're going to say, I'm going to pay, if you want to, truth in lending, one of our challenges at Wake Forest Baptist Health is that we serve the western part of North Carolina, very indigent Appalachian region, right? And we do telestroke. So they don't have the doctors in those regions to manage those patients. So they telestroke to us. We diagnose a stroke. We tell them how to manage them. But then they ship a lot of their really complicated patients to us. And guess where our readmissions are coming from? They go back to West Cupcake, North Carolina. We don't have the catch there for them. And so they have problems. They go to the ED. They get admitted to that hospital again. This is a C-suite. That hospital makes money. We get all the penalties. So if you are going to accept that patient, Medicare says you're going to be responsible for 90 days. So we just expanded and serving very underserved areas for these patients. And we're going to be held liable for those first 90 days of care. So we better figure out how to manage them when they go back to those communities, right? If this works, there is nothing, stroke is not a new event. It's just an event. These patients have underlying hypertension, diabetes, all the chronic comorbid. Healthy people don't have stroke unless they have an aneurysm, right? So we've got to start treating them as complex comorbid conditions. So we believe that if this model works for stroke, it's very generalizable to management of other complex conditions. And I think that was probably one of the reasons we got funded. I will tell you, I always want to attribute this to a colleague, Sabina Gazelle. In the first round, there were 240 letters of intent. They only let 38 proposals go forward, and they only funded 5. And we said, well, what happened here? And they said, you didn't hear us. You had to have done the grassroots to understand what the patients and caregivers want, not what the doctor wants or the therapist wants, but what, and we did that methodically. And we also engaged the community stakeholders. So that's our trial. It's an ambitious project, most ambitious thing I've ever done in my life. But I want to tell you, honestly, we've got the best team of my life. Great epidemiologists, great multidisciplinary team. There is not one of these things that's been designed. As we just sent our slide set to PCORI last night, and our educational materials. We're working with Elsevier, the big publisher. They're going to do what we call infomercials for us to educate the patients at the point of care. And it is truly a team effort. And everyone on this team is not driven by the new academic agenda or the new, I'm going to get another grant. They carry on their sleeve every day a commitment to improving the care of our patients. And that's what research should be about. Thank you very much.
Wonderful. And now we have time for a few questions. There, Dr. Raji.
Thank you for a very exciting talk, especially with the upcoming Accountable Care Organization. This is a great model for dementia, congestive heart failure. The thing that strikes me the most is the 75% non-compliance with medications, which are very critical for atrial fibrillation, all those risk factors, comorbidities. In addition to the cognitive difficulties and psychological problems, what are those other factors that are responsible for such a high level of non-compliance?
Well, they're in the medication adherence, they was 75% complied, 25% are not complied, but only 30% have their blood pressure control, okay? So we are delving into that, and what we are finding is that a lot of the patients go home, like I said, stroke is not their first condition. The average number of medications are on is 15 or 16, right? Multiple medications. And that requires a high degree of cognitive function to manage that many medicines, right? That's number one. And we didn't pick up that maybe they didn't have the cognitive, and they're not people who are demented. They've got a lot of them have long-standing vascular disease and they have early cognitive decline, right? But it takes complex executive function to manage that many medicine. So we believe that we're not picking those deficits up and providing the support to do that. The other real reason in North Carolina, a lot of people can't afford all these medicines. And so you go to the doctor, okay, we're going to have this ACE inhibitor, this whatever, and they'll give you 4 or 5 different, if you're having trouble controlling your blood pressure, what do? You give them more medications, right? And you keep escalating the cost of those. Well, they can't even afford their food, right? And so what we're trying to do is go and work with them to find out, can you afford the medication? If you can't, what medication assistance do you have in your community that we can get them? And you know what? We give them the $4 formulary at, not the patient, but the provider at Walmart. The big thing in stroke, and this, is the big thing in stroke are the new anticoagulants, right? Well, how much do those cost? Yes. And I can write them and they might be effective and I might not have an IRR. I mean, I just take it personally. I have a cousin who lives at, on Social Security. And she had atrial fib, and what's the first prescription they wrote for the new INR, not the new anticoagulants. She goes to the pharmacist at Walmart and says, ooh, I can afford this, $300 or $400 a month. Now, she was in that donut hole. And they said, well, we're going to keep this over the side, keep these medicines going, right? Until we can afford this. But we don't think about patients' ability to manage. And so we're also, and you know this, and you guys don't shoot me, everybody's looking for the quick fix. So Eric Coleman's quick fix model, right? You know what? I said, excuse me, Eric, that was tested in totally cognitively impaired, cognitively intact patients. And if they can manage all of this, they probably don't need our services, right? So yes, there are people like me who can educate, and you can educate, but it's much more complex than this. So the point of our individualized care plan is don't start spewing to patients until you understand exactly their functional and social determinants of health as well as their medical determinants. And we judge what we recommend based on that. Honestly, some of these patients adamantly say they may be falling and go to home health. I don't want home health. Okay, I heard you. I'm going to read a message to you why that's important. But if you don't want this, let me tell you why you should be concerned. Let us counsel you on that. And a lot of them actually come back to the clinic and they say, okay, I'm now ready for the nursing home or inpatient rehab I could manage. But if you don't have that support service, there's nobody to call. Call the hospitalist now, right? They don't even remember who you are. And the care coordination in the hospital is just trying to get you in and get you out. Right? Am I making this up? No. Right? So if you take mother home, right, and with all good intentions, and now I'm overwhelmed, 99.9% of the population, including physicians, unless you're a geriatrician, don't understand the Medicare regulations about getting into an inpatient or a skilled nursing facility once you've gone home. And by the way, which we found in our own system, and you all know the stay rule, 48 hours, how many hours you have to be in the hospital?
2 nights stay.
2 nights stay, yeah, 48 hours. Well, okay, you have this stroke, and I'll keep you for 24 hours, I'll shoot you in the nursing home, and then you're left with a bill for rehab services?
Thank you so much. We really appreciate it.
UTMB Health, working together to work wonders.